We have a morbidly obese patient for cesarean section. Okay. Morbidly obese patient for cesarean section. So what will be your anesthesia concerns?
So there will be concerns for an elective cesarean section.
Yes.
Okay. There will be concerns related to her obesity, and there will be concerns related to the obstetric history of the patient.
Okay. So how can you elaborate it?
Yes, sir. According to for obesity, first of all, the airway concern. This concern will be in both the cases of obstetric as well as the obese patient. In case of an obese patient, there are some other things like obstructive sleep apnea history, cardiovascular problems like hypertension, heart failure, etc. And the anatomical, physiological, and pharmacological, all kind of differences will be there.
Okay. Like, there are certain changes which are common. Like FRC, yes, there is like change FRC in the respiratory mechanics. There are chances of difficult intubation. There is more chances of comorbidities. Okay. Concerns related to obesity, you can further elaborate. There are some logistics concern. Okay. You need special monitoring equipment, shifting problems. Okay. So you have to attend all of them. Okay.
Yes, sir.
So actually it looks a very difficult question, but it's very simple, because usually you can say that 1 + 1 will be 3, not 2. Okay.
Right.
This is an article on obstetric anesthesia and obesity. Okay. So they will chalk out concerns related to, these are actually not related to much, but they can ask you these things as well. These are mainly related to obstetrical miscarriage, fetal abnormalities, premature deliveries, more chances of gestational diabetes, more chances of preeclampsia, more chances of patient having PPH, peripartum cardiomyopathy. Okay. There is nothing special, because why I am telling you this thing, that if they suddenly ask you this question, don't get worried that this is not written in the common books. Okay. You will find these topics only in okay. So here, would you like to say something about ERAS with reference to obstetric patient and obese patient? Enhanced recovery after surgery.
Sir?
Enhanced.
ERAS?
Yes.
You're asking what is ERAS?
I'm asking ERAS with reference to pregnant patient, for example, and obese patient.
Yes, sir. Sir, the ERAS program has certain, there are certain things to be considered in an ERAS program and to be done. Some factors, some things are to be done pre-operatively, some intraoperatively, and then for the post-op period. For pre-operatively, number one is the patient education and counseling. You have to discuss with the patient his condition and all the options that are available for his treatment. Then we have to keep the NPO period to the minimum most. The patient should be given carbohydrate drinks preoperatively whenever her NPO or his NPO starts. The clear fluids should be given up to 2 hours before the surgery. And I think these were the things.
Is this Is this critical even in the pregnant patient? Would you like to give 2 hours before the patient which is already considered full stomach?
Clear
Would you,
fluids,
would
I
you
don't think
comment
any problem
about,
with clear
would you
fluids.
comment about regional anesthesia versus general anesthesia? If you want early ambulation, would you like to choose GA or spinal? Yeah, like regional.
For early ambulation, it will be GA.
GA? No. You are afraid of this one motor blockade later on?
Yes, sir.
Okay, so but how will you control the pain?
Pain with other techniques like epidural or local blocks.
Okay, and early ambulation is early
Is one of
ambulation is early ambulation is early ambulation only related to motor block or anything else? If there is more vomiting or patient is sedated,
vomiting,
will the
sedation.
patient be able to mobilize?
No.
So how can you say that it's only GA which will enhance the mobilization?
There are certain factors.
Rather, it is more risk factor for bleeding. It is more risk factor for stress response. It is more risk factor for embolism. So you can say that you have to consider both factors, and then you can chalk out a plan. Am I right?
Yes, sir.
Because the concept of ERAS is to decrease the mortality, morbidity, and decrease the hospital stay.
Yes,
And this one, you have to reduce the use of medications or things which are creating more worsen post-op outcome. Okay, like what about use of opioids, benzodiazepines?
So these are all part of those. In pre-medication, we will avoid benzodiazepines.
No, that's what I'm telling you. That I'm just trying to defend I'm just commenting on your comment that GA will enhance the ambulation. Okay, so these are the factors which are against your choice.
Right.
There are so many factors which are in favor of your comment. Okay, so you have to see that you can use ropivacaine, for example. Okay.
Yes.
You can use in a way that still you are able to mobilize the patient early, because you are because of the advantages you are getting with the use of regional anesthesia. Okay.
Right.
So this was my point. Okay. There is a common, because now we have done most of the topics, so I just wanted to cover the topics which were which are asked separately in some way, that there is a patient who is coming who in first trimester for this McDonald stitch or SK stitch. So how will you conduct the anesthesia? Have you heard about it?
Yes, sir.
So how to proceed with it?
So usually it is done under general anesthesia.
Okay.
With an LMA or on mask.
LMA. Now question is that in what week of pregnancy the chances of aspiration increase?
I think after 12 weeks. I've forgotten it.
Anyone can comment on it? At which week of pregnancy the chances of aspiration increase?
Sir, after 14 weeks.
14 weeks. So at the start of second trimester, am I right?
Yes, sir.
Okay. So still would you like to give general anesthesia?
Patient was in first trimester, right? Before 12 weeks.
Yes. So can't you, because in what the level of anesthesia is required for McDonald's stitch or SK stitch?
I think T10.
Spinal and epidural are valid choices, so we can go for one of them in this situation.
Yes. My question will be, Qasim, that what level of anesthesia would you require? Like
T10.
Why T10?
Uterus and cervix.
You are right, but you have to tell. For example, if they are going vaginally, but still you need T10. Why? Cervix. Okay, because the area of cervix is supplied by T10.
T10. Yes.
Okay, so this is the question that can you do it in saddle? So answer is no. You cannot do it in saddle because you need cervical dilatation or anal dilatation or anything which is related to the bradycardia. Okay, so if you are not able to give a proper anesthesia, patient can have bradycardic response and uncomfortable. Okay, so
yes, sir. But one more thing, sir.
Yes.
Usually the duration of this surgery is very small, like 5 to 10 minutes. Okay. So when we have given spinal, we have to observe the patient for at least 32 minutes to 1 hour to be hemodynamically stable, to be shifted out of OR.
You're right. So you are right. So you have to monitor even after general anesthesia. Okay.
Of course.
So this is not the reason for it. You can defend it. You can defend in many other things. Okay. In general anesthesia, for example, sometime it is done in first trimester. Rather, I have made it 12 weeks. So actually, these things are done in early pregnancy. Okay.
Yes, sir.
So in that period, there is risk of teratogenicity. So you have to attend that thing as well. There, patient can have miscarriage, like abortion. Patient can have. So in that scenario, you have to monitor the patient anyways. Okay. You have to monitor the patient for any possible sequelae. Okay.
Yes.
So there is no clear-cut answer that GA is better or spinal is better. Spinal is better in other things. Okay. Like in GA, you can, in spinal, you will regional anesthesia, you can avoid the polypharmacy. You can avoid the nitrous oxide. You can avoid a number of things you can avoid. So there is no clear-cut indication that you have to give GA. Okay.
Right.
Duration is one thing. Even with spinal, as I told you, that internationally there are many medications which you can use, which will not cause. For example, what is the drug which has the shortest of duration?
Sir, chloroprocaine.
Yes, 2,3-chlorprocaine. Okay, it is rapidly metabolized, so you can say that. If you are worried about ambulation, so I told you that ropivacaine has shorter duration of action. Okay, so these are the things which you should be keeping in the mind, and you have to counsel the patient about the possible outcome, like unwanted outcome. Okay. So these are the things. So what about if a patient, you have a patient with twin pregnancy?
Twin pregnancy and for cervical cerclage?
No. Twin pregnancy for cesarean section.
For cesarean section.
Anyone else? Jameel, would you like to say something? Are you on call? If you're on call, anyone wants to say?
No, sir. Just sorry, Salam. You just want to know the choice of anesthesia in twins pregnancy.
You know, if they will ask you, you have a patient with twin pregnancy going for cesarean section. This question, actually, remember one thing. Any question like that.
No issue to choice. No issue to
listen. Sorry, one thing. For any scenario like that, if they ask you in the exam, Remember one thing, don't forget to mention the physiological, pharmacological, and anatomical consideration leading to altered response in your anesthesia management. This answer should be the part of your answer to start with. The rest of the things, specialized thing, what you will be taking care of it. Okay, if you are dealing with a patient with twin pregnancy. Okay, Jamil, now please answer.
Yes, sir. In choice of regarding all these, the physiological, anatomical, and pharmacological changes. After that, the concern is only there is a little bit high risk of bleeding because of true placenta, but choice of anesthesia there is depends upon the situation. If hemodynamically patient is stable and no fetal distress, we can go for regional anesthesia spinal. And yeah,
more
and
chances of bleeding, more chances of patient going in uterine atony.
Uterine atony, yes.
And
Auto-COVID compression also,
you have
yes.
to take care about the timing of
Delivery of the baby.
no, oxytocin.
Yeah, after delivery, we have to give after the second region, delivery of the second fetus.
Yes, and after giving spinal, when you are making the position to facilitate
Yes, more
the,
risk of auto-cable compression also.
yes,
Because of
so there will be more chances. So you have to keep the wedge. Then the respiratory mechanics.
tilt the bed 15 degrees, 10 to 50 degrees to the
Yes,
left.
respiratory mechanics will maybe because the abdomen is even more filled. So the respiratory mechanics will be affected more. Okay.
Yeah.
And you have to give the timing for oxytocin, you have to take care. So rest of the things will be almost the same. Okay. I'm not sure whether there is association with PIH or association with the placenta.
Yes.
Placenta previa, accreta, percreta. I'm not sure about it, but these may be the considerations which you should be knowing. Okay. Then there is another scenario that you have a pregnant patient with trauma. Okay. So how the similar question. You have a pregnant patient who underwent RTA. Okay. So how will you manage?
Yes, at the same time, we consider about the anatomical, physiological, and pharmacological changes of the pregnant patient, and the side at the same time we will assess the severity of the injury and will manage accordingly. In the same time, if the patient is bleeding, and the risk is that in this situation, difficult to to catch the early deterioration, because pregnant patients also has a high heart rate, means tachycardia, and in trauma and early bleeding also there is tachycardia, also difficult to assess the bleeding. Second, there is internal bleeding, also difficult to assessment of the internal bleeding in the pregnant patient.
Okay. What else? You are missing again the same thing, Jamil, which you mentioned a little while ago. What about the uterine tilt? And it will be depending on the pregnancy, the
duration of
the duration of pregnancy. Okay, the extent of trauma. Okay, and then the things will be exaggerated. Okay. Priority will be given to the mother in addition to all ATLS. I'm not repeating ATLS because that's not our topic, but all the care related to ATLS. In addition to that, you will be calling the obstetrician to assess the fetal well-being. Okay.
Yes.
And you will avoiding all the factors which affect the fetal.
Mother as well as fetal.
No, mother, fetal circulation. Okay.
Yes, hypotension.
Whatever you are doing, you have to keep in mind that the patient is pregnant. There is a baby, so you have to consider that thing. Okay. I don't think so there is anything specific related to if it is early pregnancy, you will and there is no clear-cut indication, you might consider risk versus benefit if you are doing any radiological studies. Okay, if you need to do radiology and the patient is in early pregnancy, or even then, you can say you will use extra protection to the mother. Okay.
And in late pregnancy, then we have avoid the NSAID, the specific configuration of the feature to just avoid the early closure of the PDA, and avoid the drugs that
I'm not very good at this comment. If you can elaborate a little bit, what will happen if PDA is closed by NSAID intraoperatively? Sorry, during pregnancy. What is the biggest impulse for the closure of PDA?
Yes, it will stop the right to left shunt that is dependent.
Jamil, I repeat my question. What is the biggest factor which close PDA? Is it prostaglandins, or is it oxygen, HiPO2?
Definitely both have the effect. Definitely, if there is hypoxia, there will be increase of the SVR left side. It will also physiological revert the shunt.
No, Jamil, I'm sorry. I'm again repeating my question. Maybe I'm not able to clear the question. Please, what is the biggest factor in the early first breath? How PDA is closed? Is it the effect of prostaglandins, or is it something else? So most potent factor is PO2, which closes the PDA. Okay, and decrease in pulmonary venous resistance, pulmonary vascular resistance. So yes, theoretically we say, but I think this is not the most important factor. So you can say that it can have some problems related to fetal circulation. Okay, because of the closure. So this is what else? What else? So you can repeat the same thing, that if there is cardiac arrest, you have to deliver the baby within 4 to 5 minutes. You have to press a little high up in the sternum. Okay, and rest of the things we have discussed. Okay. So these are few factors. Actually, I just want to show you some of the questions which I made, and we will see that if we have missed anything, we can repeat them. Okay. What are the airway changes in pregnancy? We have discussed there is engorgement, there is like chances of more airway and mucosal damage, decreased size of endotracheal tube will be required. Okay, and you have to do the laryngoscopy carefully. There are because of the enlarged breast and reduced FRC, a patient can desaturate early. There is a risk of aspiration. So all these result in challenging. So how to deal with it? You make RAM position. We do rapid sequence induction. We do pre-oxygenation. We give
for large breast, difficulty in intubation, and we can use short-handed laryngoscope.
Yes, and even we can do the RAM position, which will what will be the effect of RAM position? It will make the angles, the oral angle, the pharyngeal angle, and the laryngeal angle in a better way. That will ease your laryngoscopy. Okay. And
as well as increase the FRC also.
Yes, and the assistant can even push the breast away so that it will be easier to do the laryngoscopy. Okay. So these are some of the questions which are being asked. What is RSI? How to do it? What is Salic maneuver? Because I'm just trying to rush up, so that's why I'm speaking it out. I'm not letting you answer, but actually we have discussed everything in detail. Yes, Tayyab, what we want to ask?
Sir, polio laryngoscope have anybody used ever?
Polio laryngoscope, I'm sorry, I have not used it. Jamil, have you used it?
No, sir, I have only seen in the books only, but it's short-handed. That's why, you know, it is recommended in case of pregnancy also. Pregnant patient with large breast, you can use the polio-handed laryngoscope.
Yes. Okay. So how to give this 10 Newton and 30 Newton? If you press the weight machine and you are getting 1 kg, that is 10 Newton, and you are pressing the weight machine and it is giving you the pressure at which 3 kg, it is 30 Newton. So roughly the pressure which is easily tolerated by an awake patient, that is 10 Newton, and then you will increase it further after the loss of consciousness. Okay. And you have to remove it after you have confirmed the tube bilaterally. Auscultation, then you will remove the celiac, this cricoid pressure. And the problem related to it is esophageal rupture, difficulty in laryngoscopy you can face, and if you are not doing it in the right way, it will have no advantage, rather you will creating more problem to yourself. Okay, so more important is to do it correctly, because sometimes it's not easy to identify the landmarks, and actually you are not doing it. Sometimes your assistant is doing it, and majority time non-technical person like anesthesia technologist will be doing it, not the doctor. So that is also another problem. Okay, so what's role of and need of pre-oxygenation in a pregnant patient? We know about it. We are doing denitrogenation and increasing the oxygen reserve, so increase the apnea time. Okay, so there is a calculation for it according to the alveolar gas equation. You have to calculate with effect of vapor pressure and oxygen cascade, which we will discuss. We had discussed when we discussed respiratory system. So these are the things which is the basis of pre-oxygenation. Okay, so ramp position is actually rapid airway managed position. It is not ramped, it is ramp position, and it is to facilitate, as we discussed, that we have to bring the elevate in the way that external auditory meatus comes at the level of sternomental junction, that is angular fluid. Yes, Tayyab?
Sir, I want to ask a question about cricoid pressure. What is latest recommendation about cricoid pressure? Should we give or not?
Actually, if you ask any person who is from UK, he will say that if you are doing rapid sequence, like if you are dealing a patient with the full stomach or pregnant, and you are not doing it, you are not covered medico-legally. Recommendation, I'm not sure, but actually if you are facing problem in the intubation, you can remove it, as far as I know. Anyone can correct me. Okay, because practically I have never done it. I never do it, but what is the recommendation, I'm not sure.
Okay, sir, thank you.
Okay, so as far as I told you the rationale, usually it is, if it is done correctly, only then it will help. If it is not done correctly, it is useless. This is the point. Okay. Okay, so we do.
Sir,
yes.
in answer to Dr. Tayyab's question, the
Yes.
latest article, which was I think 2 or 3 months old, from ATOT, they have mentioned cricoid pressure for GA.
That's what I'm telling you, that it is never, even if they are saying it, please don't forget in exam. I told you that I am giving anesthesia since 17 years. I don't like it and I never use it, but I cannot claim it in the exam. Okay, in the exam it is, even for example, you can use this, that there in some studies they are saying that it is you can omit it, but it is better to do it. Okay.
Yes, sir. Listen, but it is written there. It is written.
It should be written.
It should be given.
It is never. It is, even if some research saying that it is of no use, nobody will say that omit it. Okay. Okay. So these are the details. We actually, most of the things we have discussed. What is effect on pH? PaCO2. pH is slightly increased. PaCO2 slightly decreased. Oxygen hemoglobin dissociation curves shifted to the right. What is effect on FEE1? We did not discuss it. Any effect on FEE1?
No, sir.
No effect. Okay. What about FVC?
Force vital capacity. No, only decrease on FRC. Except all
Force
parameters
vital
will be-
capacity should be decreased. Am I right? Or no? Because FRC is decreased. I myself is confused a little bit. Any comments? Is FVC? I think force vital capacity should be decreased. Oxygen consumption is increased. Lung compliance, chest wall compliance. What is the effect on lung compliance? No change. Chest wall compliance decreased or increased. What about chest wall compliance? Any comments?
decrease, right?
Chest wall compliance should be decreased. Okay. Airway resistance is decreased. Okay. Airway resistance is decreased. Minute ventilation
Increase.
Tidal volume is
Increase.
respiratory rate is increased. Bronchial and
No,
tracheal
respiratory rate, I think respiratory rate not increase.
normal tidal more effect on tidal volume than respiratory rate. Okay. Okay. Bronchial and tracheal smooth muscle tone in pregnancy is decreased.
Decrease.
Okay. And hypersensitivity of CO2 to minute ventilation due to progesterone.
Sir, in the resuscitation question, there's written why to deliver baby within 5 minutes. What is the reason for it actually?
You tell me. You tell me first. Think
I don't
about
remember
it. It's a very simple reason.
Maternal circulation is not adequate to supply
Actually,
to
because of the overloaded.
CPR, okay. Make a CPR more effective, you know.
CPR will not be much effective till the time you deliver the baby. CPR will be more effective if you deliver the baby.
Right.
Okay.
Because
Because
it's not actually beneficial to the baby. We are seeing the benefit of the mother.
My baby as well.
Yeah.
How baby as well? If you are not able to survive the baby, at least you can save the mother.
Right.
I think you don't watch movies. You will find a number of times such things. they ask a question outside, would you like to save the mother or would you like to save the baby? They give a choice.
Right.
So the hero is saying, please save my darling. I don't want to lose her. Okay.
Sir, I have one question.
Yes.
In one book, I have read that the time from incision to delivery of baby is 3 minutes. Can you explain, please, this one? This is not about CPR and something else. This is related
time
to
of
normal.
incision of, sorry, yeah, I understood your question, Doc. It's time of incision of uterus and delivery of the baby is 3 to 5 minutes. Yeah. Because of, you know, if you give the incision, after that, the uterus started to contract and started to decrease the placental blood flow. And if you take more time, definitely it will harm the baby. It will increase the pH of the baby. It will decrease the pH of the baby.
Okay, sir.
Okay. So actually, okay. So these are the questions. Actually, majority of the things are self-explanatory. How increased metabolic requirement of oxygen is compensated by the pregnant patient. Shift of the oxygen dissociation curve to the right. Reason for dyspnea in pregnancy, physiological anemia, increase oxygen requirement, okay, and decrease respiratory reserve, and also related to anemia, like compensation of anemia. Okay. Why pregnant patient is more prone to aspiration? Why it is? It is to because of progesterone effect, decreased gastric emptying. Okay. And some of the studies will say that it is now the concept is changed, it decrease not, but I am not sure. I am very traditional in some of the things. Traditionally, because of progesterone effect, there is decreased gastric emptying and also stasis. So it is one of the factors for aspiration. What is
it was, I am the one who said actually I was told,
I
but
knew
yeah,
that you will speak up. You will speak
Yes.
up, but for some time, forget that whatever you have achieved up till now. Try to be very on the basic level. These are consultants' comments, not residents' comments. Okay.
Okay, sir.
Okay. So, what's Mendelson syndrome? What's critical pH? Critical content volume? Prone to respiration? Again, I forgot. I always forget this answer to this question. At which week the risk of aspiration increases and back to when it is back to normal? Actually, you should be knowing the effects when they start and when they come back. Okay. Because in MCQ, if you are not able to know this thing, you will miss the answer. Okay. So I don't remember everything, but I think for MCQs people, I again repeat, the changes when they start and when they come back. It's very important. Okay. And related to this thing, it's actually I just faced 2-3 days ago a patient aspirated. So I will ask this question just for the sake of curiosity. Is there any role of antibiotics if patient aspirate? In what?
It depends on the aspirant. It is from stomach or it's a fecal containing.
Okay, if it is fecal only, then you will give antibiotic. Is there any role of steroids?
No, sir.
Okay. Is there any role of diuretics?
No.
No.
Is there any role of giving soda bicarb?
No, sir.
Why? If you are using it through endotracheal tube, can it help?
It will also harm the tissues. It will be also like the pH is also alkalotic. There will be alkalotic injury also to the alveoli.
Okay, but if you just lavage it, can it just theoretically increase the pH and decrease the damage? Because the more critical thing which we discussed.
Yes.
Okay, so that's the reason. You have to.
But according to my knowledge, only you can do the suction and you can remove the food particles, and you can remove the by suction the maximum fluid. But about the bicarbonate, maybe anybody should have listened to any other study, he can guide us. But I think also it's not recommended to give the bicarbonate during this aspiration or intratracheal.
Okay. What else? What are the ECG changes in pregnant patient? Right axis deviation.
Right axis deviation might be there will be not too advanced, but might be you will find some left ventricle hypertrophy, and you will find definitely sinus tachycardia also. And axis of will be more to the left, deviation of the axis or to more to the left. And what other changes, physiological changes, you can find.
Okay, what will be the physical signs you can get? Tachycardia. This one. What else?
Hypotension.
Hypotension. Okay.
Decreased systolic and diastolic pressures, 5 to 10 millimeter of mercury.
Yeah, yes, doctor, he was asking about the ECG changes, but in ECG we can find rest sinus tachycardia, mild left ventricular hypertrophy, deviation of the heart axis to the left. I think it's the normal.
Okay.
What else? Maybe anybody can add.
Okay. We know about these changes. Stroke volume is increased, heart rate is increased, SVR is decreased, blood viscosity is decreased, cardiac work is increased, diastolic blood pressure and systolic blood pressure are decreased, mean blood pressure decreased, platelet count not much effect, or slightly decreased or what?
Slightly decreased.
Slightly
Gestational.
WBC count increase, blood volume increase, RBC volume not increase as much as plasma volume. That's why there is physiological pH, physiological anemia. Okay, clotting factors all are increased except
fifth.
Okay.
Fifth will increase, all other will
No, clotting factors are increased.
sorry, increase. Yes, all the clotting factor will increase except
Okay.
fifth.
What is effect on Ag ratio?
Sorry, sir. Effect of
Albumin level decrease or what?
Decrease.
decrease dilutional. There will be dilution decrease in albumin level.
Or pseudocholinesterase level also decrease.
Yes, but
Okay.
clinically it will not prolong the effect of depolarizing muscle relaxation.
Okay, why edema occurs in pregnant patient? Overloaded circulation, stasis, low oncotic pressure. Okay, how much is the blood flow to uterus?
700 ml per minute.
700
Depends upon the stage or age of the gestation.
at term. Up to I
term,
think
yeah.
1 liter. I think
Yes,
1 liter.
will be yes, around about 20%. It will be yes, 1,500 to 2 liters.
Okay, so supine hypotension syndrome, you know about it, and how to prevent it, and the importance of this increased coagulation factors. There is risk of thromboprophylaxis. That's why even in high risk patient they are giving this aspirin and even enoxaparin, low molecular weight, for thromboprophylaxis. That's why all over the world we use regional anesthesia for this very reason. Okay, the MAC is decreased because of progesterone. Okay, mainly there may be some other reasons as well. How does requirement for local anesthetic in epidural and spinal decrease in pregnant patient? Because it's shrunken and epidural pressure is also increased. Okay, what are the effects on these things? Renal blood flow
Increase.
Okay.
GFR increase.
Okay. Urine output increase. Creatinine clearance is increase. Okay. And bicarbonate clearance, I think it is decreased or increase. I don't forget it.
Bicarb decreases as same CO2 decreases.
Okay. What else?
But
Above it was written, what is Mendelson syndrome?
Mendelson syndrome is actually aspiration pneumonia. Okay. It is aspiration pneumonia. Where is it? This is aspiration pneumonia. Okay. Okay, actually, I'm feeling quite down. I had a very long day today. So we will have one more session. We will finish the rest of the things about obstetric anesthesia. If you have not listened to the previous sessions, I would ask you to listen it. It will help you. Okay, everybody, thanks for your time. And any question before we finish?
Sir, what is other name for SK stitch? McDonald?
McDonald stitch, it's actually for us, it is for cervical incompetence. Whatever SK stitch or McDonald's. On a funny side, actually, SK we have special. I have special respect for this word SK because the name of my supervisor was Shaida Khoja. So I have very special respect for SK because she was SK.
Okay.
Okay, all of you. Thank you. Thank you. Inshallah, we will meet later on with one more session for obstetric. Any question, you can ask me anytime on WhatsApp. Okay. Thank you. And a special thanks to, where is he? He has gone already. Anyways, see you inshallah. Assalamu alaikum.